Hello everyone, welcome to another episode of Ultrasound Podcast, where we dive deep into the cutting-edge practices and game-changing innovations in the point-of-care ultrasound. Today, we have an extraordinary guest joining us. He is none other than Dr. Adrian Goudie. Adrian has an illustrious career in emergency medicine with a very special interest in ultrasound. He is a specialist in emergency medicine at one of the busiest hospitals in Perth, Western Australia. Adrian is not just a leader in his field. He is a trailblazer with a passion for pushing the boundaries of what is possible in emergency medicine. Adrian has been at the forefront of integrating advanced ultrasound techniques right into the heart of emergency medicine. I am truly thrilled to have Adrian in the podcast today. So without further ado, please join me in welcoming the one and only Dr. Adrian Goudie. Hi, Adrian. Thanks for joining us. Ultrasound in advanced life support. This is such an interesting topic. And this is probably one of those most used technique in the emergency department in those time-critical, life-threatening emergencies, cardiac arrest, peri-arrest scenarios. So I thought that we'll talk about it a little bit. Recently, you have got a very interesting paper. We'll go through that as well. There is quite a bit of controversy in terms of use of ultrasound. There is a lot of controversies in terms of should we use it? Should we not use it? Some of the authors say that it can be harmful. On the other hand, there are some of the authors who said, this is a new approach, it's very useful, very informative, let's use it. In your paper, along with Michael Blavis and other co-authors, you have given a very interesting and very comprehensive discussion and debate about this. So tell us a little bit more about the evolution of ultrasound in advanced life support over the last 40 years or so.
Thank you very much for the opportunity to come and talk with you today about this, because as you say, this is a very interesting topic and is an area where there is a lot of enthusiasm. And it's a time when time counts. And so there is often a lot of pressure for people to be asked to do this. And we'll talk a little bit about the techniques later. So if we look back, in like a lot of ultrasound in the emergency department has now been going probably for about 20 years, maybe a little bit more. But it was used outside the emergency department. And so in terms of in the setting of advanced life support, that really used to mean in the cardiology department, because they were the only people who had the machines available. But there was some case reports. There was certainly no big series, but there was descriptions of patients who were arrested, usually on the coronary care unit or in the cardiology department, where because there was a machine available, they could have a look. And so there was descriptions, particularly looking at tamponade and trying to try and choose which patients might benefit from pericardiocentesis. Mm-hmm. Now, just like ultrasound across the board, as the machines got smaller and we had that real revolution of size of machines that happened around the very late 90s and early 2000s, where suddenly these small portable machines became available. And so this was one of the areas that people started looking at, and they said, well, we've got these machines now. We can start looking for these potentially reversible causes so that we can guide our advanced life support better than we can if we don't use them. There were some fairly early series published. Again, most of these tended to be in hospital to start with. And then there's been a sporadic number of case series reported, some in the emergency department, some in hospital, some in theatre, and some with the ambulance, particularly some of the European emergency services, where they sent out doctors who had portable ultrasound machines. So you had people like Raoul Kreutz, and my apologies for the pronunciation of his surname, who in Germany published some very early series about the potential use of ultrasound in this group. Since then, there's been uptake by the colleges all around the world, the critical care societies, emergency intensive care and anaesthetics, where they've really endorsed this and have said, let's get all our trainees able to learn how to do this. It's become really one of the core uses within critical care training in many places around the world. And that's sort of where we're at today. But we're still a little constrained because, like many other things, we're at the point of lots of case series, lots of descriptions, a lot of opinion. But when you really draw down to it, not so much evidence. And I know we're going to go on to this shortly, but now we're in this sort of quandary where we have some societies as focusing on the potential, this should be good, we should all be doing it, and other societies looking at it and going, well, where's the evidence? We haven't got much evidence. Maybe we shouldn't be doing it without evidence. And that's really what the paper that we wrote was trying to address.
I think I completely agree with you that we are using it, but there is a lot of scopes for evidence to support what we are doing. So we are still probably in anecdotal phase rather than evidence-based phase. That brings up the topic, broad topic, that point of care ultrasound in the emergency department that we are using not only for cardiac arrest, peri-arrest scenarios, but we are using for a lot of other things, and that can help in those situations where the patient may develop cardiac arrest within the next few minutes. Tell us a little bit more about it. What is your experience over that?
Yeah, so I think like everybody who's treated any patient who's in cardiac arrest, a lot of the time you really wish, I wish the patient had been here, I wish I'd been here, I wish we were doing this 10 minutes before they arrested, because we're much more likely to get a good outcome if we can do things before rather than after they've actually arrested. From a learning point of view and a practice point of view, in some ways it's quite fortunate that the things we look for in the peri-arrest situation are pretty much the same things we look for in the cardiac arrest situation, with one main difference, and that's cardiac. Is there any cardiac contractility or not? Mm-hmm. So that, as I said, that makes it easier in many ways for people to learn, because they're not learning a totally different skill set. The ultrasound that I do in the patient who has arrested is very similar to the ultrasound I'll do in the patient who's looking like maybe they're going to arrest in the very near future. So, as I said, in terms of teaching people and learning how to do it, in terms of the equipment and the approach, it's very, very similar.
So it's always very important to learn the very basics and practice on the basic skills, and then one can apply that in those time-critical emergencies like cardiac arrest.
Yes, yes. And as you say, I mean, that holds for pretty much everything we do. Trying to learn how to do something in the setting of a cardiac arrest with all the pressure and stress of that setting, not a great time to be learning the skill de novo. You do have to learn to use that skill in that setting, but it's like, I'm not going to turn to a medical student who's never put a drip in and say, hey, why don't you learn how to try and put a drip in here? It's like, you learn that on the setting where everything's nice and calm, there is no time pressure, and if it doesn't work, well, it's not great, but it's not such a big deal. So, yes, certainly you want people to be trained and proficient so that when they have to do it, when both the consequences are very great and there's a lot of time pressure and stress, and in the cardiac arrest setting, lots of other people go around, lots of other activity going on and everything else happening, that when they do it, then they're already pretty slick at it.
Exactly. And that we have briefly talked about these different resuscitation societies and um, the councils, ILCOR, for example, American Heart Associations. They have made a lot of recommendations. I found the recommendations sometimes a little bit overwhelming, bit controversial.
Yes.
Tell us a little bit more about this that you have mentioned in your paper as well.
Yeah. So, I mean, as everybody is aware, most of the recommendations come from ILCOR, and then they're mirrored almost exactly or with minor modifications by most of the other resuscitation groups around the world. So ANSCOR for us, the American Heart Association, and so on. So they do have quite a, if you try and look at all their recommendations, they've got lots of recommendations. So their main recommendation for the use of echo or ultrasound in cardiac arrest, they had a recommendation a couple of years ago, and I'll just refer so I make sure I quote the correct year for this, is that in 2020, they warned against the use of POCUS for prognostication. And then in, I think it was 2021, they made a statement that warned against the routine use of POCUS during CPR to diagnose reversible causes. But they did qualify that and say, although it may be considered when clinical suspicion is high and when it is performed by experienced personnel without interrupting CPR. And so the thing that really triggered this paper that I wrote was, we have the emergency medicine colleges in the UK, in the US, and certainly here in Australia, who are recommending and saying all emergency trainees must learn this. All emergency practitioners should be able to do this. And by implication, that we should be doing it in cardiac arrest. And then you have ILCOR coming out with this, well, hold on, not so sure most of the time, maybe occasionally if you've got the right person and the right setting. So there's this real difference in the level of enthusiasm. Now, interesting, ILCOR in some of its more specific recommendations in specific settings is much more supportive of the use of ultrasound or echo. So, for example, when they talk about cardiac arrest in the operating theatre, they're quite supportive. When they talk about cardiac arrest post-cardiac surgery, they say it should be done. But in the general setting, which is what we usually deal with in the emergency department, they're much more reluctant. And I would say, they recommend against its routine use. So, as I said, the thing that triggered this paper was to say, well, why are they saying that? And yet our college is saying everybody should learn this, everybody must know how to do it. It should be a basic skill for all emergency practitioners. And sort of we expect you're going to be doing it. We want you to be doing it. Absolutely. The other societies, as I said, the other resuscitation societies pretty much mimic the ILCOR suggestions, although they vary them a little bit. But they tend to hold the same line as ILCOR.
Yeah. So I think the basic recommendation from all those three bodies are probably that the main component of a cardiac arrest is CPR. Do not interrupt CPR. You can do ultrasound, do not do ultrasound, but do not interrupt the CPR. I think that is what they're emphasizing too.
Yes.
And then for ultrasound, again, they are supporting their recommendation on the basis of available evidence. And that is a huge scope for further research. And
Yes.
Yeah, it will be interesting to see over the next few years. Lot of new research comes into these fields, and hopefully that will change the recommendation from those societies.
Yes. Yes. I hope so. And I mean, I think the reason we're in this situation at the moment is because we don't have really good evidence. I mean, what we have is very little evidence. We've got a lot of anecdotes, we've got some supportive stuff. And, you know, it's also very easy to interpret some of the evidence that we have as being quite negative. But I think that's actually an error as well, because I mean, we can talk about the specific evidence a little later if you like, or we can talk about it now. But most of the evidence has been on observational studies. And there is this thing there's a lovely phrase that is sometimes used in resuscitation research. And in a lot of observational studies, so not in the resuscitation setting, in a lot of observational studies, they have a thing called a mortal time bias, which actually means that most interventions may look better because if you are in the group, if you're a member of one of the observation groups and you die early, you probably don't get the intervention. So getting the intervention is a sign of living longer. Now, in resuscitation, it actually works the opposite, and they have a thing called resuscitation time bias, which is that if your intervention doesn't happen until a little while into the resuscitation, then the patients who get that intervention generally are going to have had longer resuscitation, and they're going to have a worse outcome. And this is certainly one of the things that I think we see with ultrasound. So, for example, in the study that came out of Taiwan, which is one of the best studies, I think, their protocol there is that if you don't have ROSC by 10 minutes, then you do ultrasound. So, of course, if you go back and you do your observation group, everyone who's had ROSC in the first 10 minutes are in the no ultrasound group.
Right.
So guess what? They have a better outcome. And if you don't realize that, then you look at those figures and you look at them and you say, well, ultrasound doesn't help at all. And in fact, it looks like ultrasound makes things worse. And that was, again, one of the things that we mentioned in the paper, that in that case, the ultrasound is actually may well be a marker of poor prognosis rather than being a cause. But of course, this is supposition because we don't have the evidence. And we have to be, have enough humility to remember that there are many examples in medicine of doctors doing things that they absolutely, completely and utterly believe were good for the patient that turned out to be completely and utterly bad for the patient. So, I believe that doing echo in the setting of cardiac arrest, if it's done correctly, can be beneficial. But I also like to remind myself that me believing that is not the same as saying it definitely is and that we have proof that it is. And so, again, one of the reasons for that paper was to make a call to say the only way we're going to answer this is to do a proper randomized trial, not to look at observational trials, because the evidence is not going to be able to be teased out from those trials to tell us whether or not we should actually be doing this or not, or if we should be doing it for everyone, should we be doing it for a subset? How should we be doing this in order to get the benefit and not create harm?
Excellent. Thank you very much. So, Adrian, a little bit of basics about the use of ultrasound for the assessment of cardiac arrest situations or resuscitations. Tell us a little bit more. In your paper, you have mentioned in those 5H and 5Ts, and there are few of them like hypovolemia, cardiac tamponade, tension pneumothorax, and the pulmonary embolism, myocardial infarction. This can be very useful. What is the evidence behind it?
Yeah. So most of the evidence, as I said, comes from observational. So in fact, all of the evidence comes from observational studies. And depending on the series, because that very much depends on the settings that they were done in general, most of them say that they find about 15% of cases where there is one of the potentially reversible causes. So as you mentioned, the hypovolemia, the pulmonary embolus, the tamponade, and the tension pneumothorax. I mean, those ones in particular are the ones where our management is going to be not just slightly different, but actually very different. There are specific things we may well do that we won't do if we don't think that's the cause. So that is one of the uses, is to look for those potentially reversible causes and to modify our algorithm to do very specific interventions. The other potential benefits that most people are very aware of is the prognostication. And we've got to be a little careful with that. I think early on, people overdid the belief of how good ultrasound was for prognostication. And this is one of the potential harms. And this is why both the European Resuscitation Council and ILCOR have now made actually very specific statements about not using ultrasound as the sole determinant for prognostication. So this is going a little bit down this rabbit hole, but you have to remember, when some of these original series were described, you had people coming out and saying, if there is no cardiac activity, then the likelihood of surviving to hospital admission, let alone hospital discharge and or good neurological recovery, was zero. It's a definite, that's it, zero. You have a look, no cardiac contractility, zero chance. So by implication, you stop then and there. Now, the problem with that was, of course, the people who were there doing the ultrasound were in the arrest. Everybody could see that. And so you sort of had this risk of a self-fulfilling prophecy, because if you look and say there's no cardiac contractility, therefore there's no point proceeding, therefore we're going to stop resuscitation, well, guess what? The patients died. Therefore, they had zero chance of survival. So, of course, if you're going to evaluate these things properly, you have to evaluate them where they don't affect your subsequent management, and at least initially. So that paper, there was then a big paper by Gaspari in, I think it was 2016 or around about that. And I think that was a very important paper. Number one, it was big numbers, multi-center. But number two, in that paper, their rule was that no matter what you saw on certainly the first ultrasound, you had to keep going at least one more cycle of CPR. And what that showed was that lack of contractility is, it's a dismal prognostic sign. It's a very bad thing. You hope not to see it, but it's not absolute. So just like all those other things that we use for prognostication in the setting of cardiac arrest, the pH, the potassium, how long this has been going on for, the age, all those things, you can look at that and say, oh, all of these things are very poor prognostic signs, but pretty much none of them on their own can you say, this is it, absolutely zero on it as a standalone indicator, we can say, this tells me there is a 0% chance of survival at this point.
Mm-hmm.
So certainly I use this. I use it in conjunction with all of the other information when I'm prognosticating, knowing that it tells me that this is a really bad sign. And in that setting, usually in the setting of it's also prolonged resuscitation, there has been no ROSC at any point. You may or may not have other features like pH and potassiums. Then we may well say, with all of that information, we're going to decide to stop at this point. But I completely agree with the statement by ILCOR and the European Resuscitation Guidelines that says it's not a one-off standalone. So if somebody comes in and after 5 minutes of CPR, I see cardiac standstill, I'm going to keep going. I don't stop at that point, just on that one feature. The third area of use where we assess resuscitation is one that I think isn't so widely used or even as widely known, and that is to try and help guide your cardiac compressions. And this has generally been used in the setting of transesophageal echo.
Yes.
And what they looked at is when you're doing your CPR, are you actually compressing the ventricle, or are you actually compressing the left ventricular outflow tract, which we believe is a bad thing. And what they showed is a lot of the time where we think we're compressing the ventricle, we're actually too high up on the chest and we're compressing the outflow tract, and we may be impeding the outflow, and therefore we should move our hands. Now, that's much easier to do with transesophageal echo. It would be very difficult. I've heard some people describing doing that with transthoracic echo, but most of the time that's people talking about using transesophageal echo. My understanding is there's not many places in Australia that do that, certainly within the emergency department. In my department, we don't have a transesophageal probe. We don't do that. We just do transthoracic. But in the future, and again, we need evidence. This may be something that if it's shown to be beneficial, maybe there will be a call for us to say we should be doing this as part of our standard ALS.
Yeah, there is a lot of debate about that topic. The other topic that recently is coming, Adrian, is the use of the ultrasound for placement of the tube. And I believe you have mentioned that as well in your paper.
Yes. So again, there are some places that do this in Taiwan. They've got a fantastic program over there, and they use the ultrasound to help confirm the intubation.
Yes.
It's something I have done. It is not something I do routinely. I think the role these days in the setting of video laryngoscopy means that maybe it's not quite as necessary as it might be otherwise. The days where you're trying to intubate somebody without video laryngoscopy with just a direct view, that used to be pretty tough sometimes in these patients. While again, you've got a lot of time pressure, in that situation, it was pause the CPR while I try and get the tube down. Whereas now, a lot of places with video laryngoscopy, they'll say, no, you keep going, we put the bougie down with CPR, we try and then pass the tube either while CPR is going on or with the briefest of pauses while we put the tube past the cords, and then you restart CPR very rapidly. So it can be done, and I think it's probably, rather than its main use would not be in the routine cardiac arrest patient, its main use is going to be in the patient with a very difficult, predicted very difficult airway, where you maybe can't palpate the trachea and you want something to try and give you some guidance before you start. So, and certainly the settings we've used it in have been more in those settings rather than the routine CPR.
Yes, thank you very much for sharing that. Now, you have mentioned about prognostication of resuscitation. Thanks for that. One of the things that really I like is that the ultrasound can be used not only for the CPR itself, but it can be used for other things as well. For example, getting an IV access, or as I mentioned, confirmation of the endotracheal tubes, which can be very useful. Do you have anything in mind to talk about the different techniques or best practices for the use of ultrasound in advanced life support?
Yeah, so I think one of the things I'd say is, and this is where we get back to those potential harms, and this is one of the things the ILCOR guideline focused very heavily on, is you do need to be doing this well, because there is a real potential to cause harm. And the way that it can do that is by interrupting CPR. And we know, I mean, of all the stuff in CPR and ALS, a lot of it, the evidence is murky. But one of the things we are absolutely very convinced of is that long pauses of CPR are very bad for outcomes. So the more you can minimize those breaks, the better your chance of successful resuscitation. And what we also know from a lot of the early observation studies is that if you start doing ultrasound, you can make those pauses much longer. Now, since those studies came out, and quite rightly, people got very alarmed at them, there's been a lot of work done on saying, well, how can we do this without interrupting CPR? And so there are certain protocols. For example, Vijay's group in Sydney did the Coach Red protocol, and there are other various versions, very similar protocols from all around the world. And so the first thing, if anybody says to me about techniques and best practices, I say is you've got to do this without prolonging your CPR pauses. And if you can't do that, then maybe you shouldn't be doing this, because you might be causing more harm. So I agree with ILCOR on that. My difference is that I think you can do this well without causing harm. And certainly the way I do this when we do this, and we do this routinely, if there is people who are capable of doing echo, then we will do this in most of our cardiac arrests. And we come in, we get set up if we get the notification, and we let everybody know we are here, we are going to be doing an echo. We are going to be doing an echo while you do the rhythm check. And I say specifically to the team leader, if I'm the one doing the echo, to the team leader and to the person who's on the defibrillator, that I will be doing this echo, so I will be in contact with the patient while you are looking at the rhythm to check the rhythm. Now, if it is a non-shockable rhythm, then you restart CPR exactly the same as you would as if I wasn't there. If I'm in the way, I get pushed out the way. You just restart CPR. Do not prolong your pause because I'm there. I do say to the person on the defibrillator, be aware I am going to be there. So, they are supposed to check everybody's clear before they defibrillate. If I hear the word VF or I hear we're going to shock, that I will get out as quick as I can, but please do make sure I am off. I'm no longer touching when you do that, because I don't really want to get shocked. Hasn't happened yet. Don't think it's going to, but just so everybody's aware. And I say to them, the only time that me doing this should change what you're going to be doing is if I see something that says you don't need to restart CPR. So, for example, occasionally we'll do this and I'll have a look and they say, all right, rhythm check. And they're looking at the ECG monitor and they say non-shockable rhythm. And I'll say, there's good contractility. I'm feeling a pulse. Yeah, I think we've got a pulse. So you don't need to restart CPR. I guess the only other time is I might say something like, there is profound hypovolemia, there's a hypodynamic heart, you need to give fluids and there is animal studies that say in the setting of hypovolemia that CPR may actually be harmful. There's no human studies, but there are some animal studies. But so most of the time, I try very hard to say, me being there is not going to change your process. The main time it will is if I see something that I say, hold on, you need to do something different. Like there's tamponade. The heart's beating, but it's tamponading. Doing CPR in that situation isn't going to help. What's going to help is getting a big needle and doing, draining the pericardial effusion. Or it's hypovolemia. What's going to help is getting some fluid in there, not actually restarting CPR. Okay. So that's my first point in terms of technique and best practice is do it right. And it takes practice. You've got to be used to that. And you've got to have a team leader who is confident enough to say, restart CPR. They don't turn to me and say, can I restart CPR? They just say, restart CPR. And they do it. And that's the way it should be.
Yeah, every second counts, and this is a synchronization between the person who is doing the echocardiography and the team leader and the person who is defibrillator. It works so well.
Yeah.
When they're all in the same page.
Yes, and when everybody knows, and when everybody's aware of what's happening and they've had a bit of practice with it, then yeah, absolutely. Moving on beyond that, a couple of other things I'll say in terms of technique is a lot of people talk about doing and I've just been talking about it, doing this during the pulse check. I would also say don't limit yourself to just waiting for the pulse check. There are a lot of things you can see while CPR is going on. And one of the things is I might look and I'll show you a few examples of this if you like.
Yeah, that would be fantastic.
Yep, I can share my screen. Okay, hopefully that's coming through for you.
Yes, thank you.
Okay, so this was actually during a pulse check, and these are just some of the things that, everybody's quite familiar with these and we look for here. There's a small left ventricle, a large right ventricle, septal flattening. This was a young lady who unfortunately had a massive PE, and this was during the pulse check. But if we look at some of the other ones, obviously this is during CPR.
Yes.
Now I can already tell that there's a pericardial effusion there.
Absolutely.
So, I mean, I can't tell on here is there cardiac contractility with it, but I can tell there's a pericardial effusion. So we're already that one step ahead. And then based on the setting of that, we can decide what we're going to do. And we thought this is a dissection, and in that setting, it was an unsurvivable injury or an unsurvivable illness. But you can often see pericardial effusions while CPR is going on. If we look here we can see, and I don't know if my pointer's coming up, but we can see here is the artery, and this is during CPR. Here we have a non-compressible vein.
Wow.
So we diagnosed a DVT. And again, it's not a great leap of, here's a patient who's just collapsed, who's got a big DVT. It's due to a massive PE. So, this was enough for us to thrombolyze this patient just based on the rest of the story was also consistent with the PE. So once we saw this, it's like, yeah, we've made the diagnosis. Again, didn't need to wait for the pulse check for that. Here we've got, again, a patient getting CPR, and here we can see this is a large aorta, and this is somebody who complained of severe lower back pain and then collapsed. And in this setting, we diagnosed that this was very likely a ruptured abdominal aortic aneurysm.
Wow.
So I'll stop screen sharing there. So that's my second point, is that don't wait for the pulse check. You can do a lot of other things as well. You can also look for your tension pneumothorax if the setting is right. You can look for free fluid in the abdomen. You can look for massive pleural effusions if you think they're hypovolemic from massive pleural effusions. So we can do all that while the CPR's on, and then during the pulse check, we've already limited a lot of the things we're looking for finally. The third thing, as you've said, is that it can be used for a lot of those procedural things as to guide them, such as vascular access, which may otherwise be particularly difficult. Right.
Yeah, thanks for sharing those interesting cases. And the techniques that you have mentioned, they're so amazing. We use this all the time, but again, there is so much areas to learn, especially for these new doctors, new trainees. They have got a lot of scopes to learn these techniques. So Adrian, training is a big area, especially in this type of time-critical emergencies, as you have mentioned earlier, that we need to train ourselves, we need to train in so well that in those adrenaline rush in a time-critical emergencies like a cardiac arrest, we don't have to think twice. We will be synchronized, we will be in the same page with the team leader and every member of the teams, everybody will know what we are doing. And the only way you can do that is by training. Tell us a little bit more about it. What we can do better.
Yeah. So, I mean, as you say, it comes down to training, it comes down to practice. Echo, I think technically, echo is probably the most difficult of the ultrasound skills that we ask our trainees to learn. It's generally, it's more difficult than doing a FAST scan. It's more difficult than doing an abdominal aorta scan. Each of these things has subtlety. Sometimes the patients are easy or difficult, but overall, I think echo is more difficult. So it takes more practice. And there is really no substitute for that practice. It's the flip side of that is, fortunately, particularly when we're talking about the peri-arrest and the cardiac arrest patient, we're not looking for subtleties. It's lovely to get that beautiful, perfect cardiac view that shows everything that you want to see. It doesn't happen very often, and certainly in these circumstances, it doesn't. But, I can diagnose a large pericardial effusion even if I haven't got a perfect view and I can't exactly line up all my valves and I can't get a parasternal view. I mean, if they're doing CPR, I'm probably not going to get a parasternal view. I often find, though, if patients are on one of the mechanical compression devices, like the Lucas is the one that we tend to use, often taking the probe and just moving it around the plunger, you usually find a view there that's actually often quite good. It's sort of not quite an apical forechamber, it's not quite a parasternal, it's a sort of something view, but it's good enough to tell you if there's a big pericardial effusion. It's good enough to tell you if there's cardiac compression. We traditionally go for the subcostal view, and often that's really good. But if a patient's been bagged for a long while and they've got a stomach full of gas, you might get nothing from there, and so you're better off going up the chest, so just move around. So as I said, we've got these sort of two sides that, yeah, it's technically difficult, but fortunately we're not after perfect views. We can actually get the information we need, often from views that in other settings we'd look at and go, oh, geez, they're awful views. It's like, I don't care. It tells me what I need to know. But it does take practice. And there's no real way around that. There is, the machines are getting better, but the trainees still have to learn, they still have to practice. And yeah, I don't know any other way to do it. And so I tell them, do this. And I know, it's hard work working in the emergency departments. They're busy people, but it's worth trying to learn these skills because, as I said before, the same skills will also help you not just in the cardiac arrest patient, but in the peri-arrest patient, and even maybe slightly before peri-arrest in the, gee, they're just really sick patient, to try and prevent that cascade. And the earlier you get in, the better. So they're really, really useful skills. And I really encourage all the trainees to learn them, to practice them, and to get over that initial hump where, when you start, it's really hard. You don't get good pictures and it takes you a long while. You just got to keep at it until you start getting pictures and it doesn't take you as long. And then you get pictures almost all the time and you're really actually quite quick at it. But you just got to go through that learning curve. And fortunately, we've got more and more people now who can help guide people through that learning curve, because it is a lot easier if there's somebody around to help show you that pathway. And there's credentialing pathways, and I mean we've chosen the minimal number that we can. I don't think we've set the bar too high. I don't think we could set it any lower when we sort of say, look, 25 scans to try and get this. Mm. But even if you're only on scan number 20 or 21, have a look, because you're probably going to, in the cardiac arrest setting, you haven't got much to lose, and you're probably going to be able to look to see something that may well be helpful.
Yes, it's such an important thing, this training. And one important aspect, Adrian, is that there is no hierarchy, I would say. There is no hierarchy for the clinicians to learn this essential skill. Even a consultant who is not trained during the registrar years can get trained. A medical student, I know that many of the medical students, I am training them. And when they will become a registrar or a consultant, they will be super confident in dealing with this.
Yeah. I mean, I keep awaiting the day when all the medical students have access to machines, because I look back and I go, the biggest problem for people is time. And as I said, it's hard. You work a long shift and it's really busy. And then someone says, oh, do you want to go and spend 20 minutes doing this? And you're like, oh, it's 10 o'clock at night. And tomorrow I've got to be back. And, the time in your medical career when you have time to learn is when you're a student. You've got time to go around on the ward or in the department and spend 20 minutes with a patient, because that's why you're a student. So I really think that it will be wonderful when we give them the opportunity to be able to learn these skills when they've got the time to learn them. And then as soon as they start being doctors, they're already so far ahead. And then they can, they're transportable skills. You've learnt this in this setting, but it's really useful in this other setting. You've learnt to look at an aorta and a kidney. Well, it's not that much more to learn to then look at a uterus and an early pregnancy. So I agree with you, and I've been waiting a while, but I certainly hope we eventually get there.
I know that I think we are quite behind US in this sector. In the US, the medical students are learning these things very well, but I know a couple of universities here in Australia that they are a bit hesitant to add this as a part of their curriculum.
Yes. Yeah. And there are a lot of reasons. I understand their reluctance in that they've already got a full curriculum. It's costly either for the student or for the university, one or the other. And because it's really hard to get enough teachers. If you suddenly say all medical students have to do this, well, I mean, it's taken us a long while in the college to be able to get to a point where most registrars, the emergency trainees, have access to people who can train them. So I understand their reluctance, but I agree with you. I think it's a bit of a missed opportunity at the moment.
There is the good thing is that things are changing and people are waking up. And I hope that over the next few years, things will change on the positive direction.
Yes.
So, Adrian, you have already mentioned a couple of challenges. Tell us a little bit more about it. What are the challenges you find in case of the applicability of ultrasound in advanced life support, and how we can address it?
Yeah. Look, I think the main challenge is getting enough people trained and credentialed so that they can do this. To me, that's still the biggest difficulty. Even in the place where I work, where we've got a really strong ultrasound team, some fantastic people, we have lots of opportunity for the trainees to learn. But it's hard for them because they've got lots of other things to do as well, not just learning, but the actual day-to-day work. So I think that is still the major challenge. The availability of machines was a challenge for a long while, but I think most places now have machines available. They might not have as many as they would like, but most places still do have machines that they can access and use in the department and in these settings. The other big challenge that, again, we've already mentioned is that we actually need some better quality evidence. We need a proper prospective randomized trial so that we can turn around and say, yes, this is good and worthwhile to do. And then we can start teasing and going to the next step, which is then, okay, how do we improve? How do we do it? How do we select which patients it is beneficial for and which patients it might be more harmful for? And then really, like everything else in medicine, trying to then be a little more selective, or indeed to say, we can't be selective, we should just do it in everybody, but we should do it this way to maximize the benefits and minimize the harms.
Thanks for sharing those. I hope that we can address those challenges in the future and make it better and more accessible and better trained clinicians. Impact on the patient outcome, that's the crunch of the matter.
Yes.
Let's talk about a little bit about this interesting topic, Adrian.
Yeah. So, as you say, in the end, everything we do comes down to what's the effect on the patient. That's why we do things. And unfortunately, at the moment, we just don't know. What we do know, there are two main studies that I refer to in the paper that we wrote, one from Taiwan and one from Korea, that have looked, they're both observational. So the one from Korea, which looked at 2 time periods before a training program, and in the early phase, most of the patients did not get ultrasound, and then later most of the patients did. I'll just refer to, if you like, I can actually bring up and show you. I might share my screen again with this, if that's all right. Share that, and there we go. So this is actually the study from Taiwan. And as I said, if you look at this, you say the no ultrasound group had better return of circulation, not statistically significant, but their survival and their good neurological outcome were better. But as I said, the thing that needs to be remembered in this study is that their protocol was you didn't get ultrasound until 10 minutes. Right. Now, even if you don't have that as your protocol, it may well be that in your environment, you don't do the ultrasound until the patient's brought in, they're hooked up to the monitors, the machine might not be there, it might get breading, you might have to get someone to do it. So there may always be an intrinsic delay. So whether it's formal in a protocol or even informal, this comes down to that other issue where, as I said, it brings in this bias. This is the other case series, which is from Korea, which showed no real difference except a lot more procedures. But again, doing a lot of procedures, if you don't get a benefit, well, that takes a lot of time. They're often very senior people, a lot of resources, that might be used better elsewhere. So this
Interesting.
comes back to that issue that we don't know really whether this is good or bad. We need to know whether it's good or bad. We'll describe cases that they've had some fabulous saves. I mean, realistically, like everything in cardiac arrest, if you can do it before they arrest in the pre-arrest setting, it's likely to be much more effective, but occasionally even in the arrest setting. The other thing is that if we can identify a group where it is not worth continuing with the resuscitation efforts, that's actually a big thing as well. You know, cardiac arrest often takes a lot of resources in a department, and if the outcome is going to be very poor, then maybe those resources are better spent elsewhere. You know, we don't, if we took this to a ridiculous extreme, you know, we wouldn't say, no, every patient who comes in is going to get 4 hours of CPR with all the senior doctors in the department, because we'd never get anything else done. We'd never be able to help all those other patients.
Mm-hmm.
So if this can help us identify patients who resuscitation should be stopped earlier, then it's a good thing, which is why those early studies tried to do it. But we have to bear in mind, it's not an absolute thing. But nonetheless, I do find it helpful, and it's one of the features that I help to use to decide whether or not to stop resuscitation efforts. But as you say, at this stage, this is pretty much a big question mark, because we just don't have the evidence yet.
There is a scope of lot of works to be done in this field.
Yeah.
So that brings to this interesting topic, the future. We talked about the evidence. We talked about quite a few things about it. So tell us a little bit more about what can we do in the future? What is waiting for us in terms of technology, in terms of evidence, in terms of the patient care?
Yeah, I mean, it's always interesting to speculate on the future. It probably won't happen the way that we predicted, but I do think that the number of people and, you know, the younger trainees and the younger consultants now are certainly much more au fait with this technique. There's more and more of them who are getting able to do it. So I think, provided the evidence supports it, that it is going to become a standard technique, more so than it is currently. There are some people who talk about it crossing into the pre-hospital setting. And again, that would need to be looked at and decided, is this of benefit overall? For exactly the same reasons, the same concerns that we've got to make sure it's not going to be harmful. I mean, in the setting of interrupting the rest of the resuscitation efforts, if you're talking about a pre-hospital setting, that's even more difficult because you've got fewer people. You know, where I work, it's a big department. We've got lots of people. We can always get an extra set of hands pretty much, especially in the setting of cardiac arrest. If you're in an ambulance or on scene with an ambulance crew, there may not be an extra set of hands. So there's a real concern that we have to make sure that what we're doing is the most effective thing we can do with very limited resources. But it's got huge potential, because if they can pick the patients who need different management, because they're there pre-hospital, it's much earlier, it's probably going to be more effective.
Absolutely.
Similarly, if they can pick the patient where prognostication may be able to be used more effectively, that may also alter things as well, although that's probably a stretch in the pre-hospital setting. You've also got things like the machines are getting better, the image quality is getting better, and the machines are now starting to have ways where they can guide people to try and improve their image quality. So some of the machines now are coming out with techniques, and that'll say, angle your probe further up, rotate your probe. In the setting of CPR, it's probably going to still be very difficult because, as I said, we're often using non-standard windows and our images may not align with the perfect images that the artificial intelligence algorithms in the machine have been trained on. But nonetheless, I think that it's going to be easier for people to get adequate images in the future as the technology improves. We may move to transesophageal echo, and that may give us much more standardized views because we're not having to work around the cardiopulmonary resuscitation. And we've seen a lot of these things become a lot more cheap, or become a lot cheaper across a lot of the procedures that we do. So maybe in the future we're going to have cheap enough transesophageal echo probes that maybe even an emergency department's going to be able to have some. Then we've got the issue of training with them. But as I said, if you've got automated algorithms that can do a scan and then generate automated images or more standard images, then that may reduce the training burden. As I said, I think that's probably more in the realm of for transesophageal echo than for transthoracic echo in the setting of advanced life support. There's also, there's a lot of clever people out there coming up with some wonderful ideas about how ultrasound may also be used for things like detecting pulses. We know that feeling pulses in advanced life support is awful, but maybe people talk about ultrasound of the carotid or the femoral arteries to look and see whether or not there's output, and that's probably much more accurate than feeling pulses. So that may be taken further as well.
Thank you for sharing those. The future is bright, that's all I can say. And with more training, with the advancement of the technology, as I've said, the machines are getting better, cheaper, and smaller. And some of the new machines, they are even wireless. You don't have the wire, you can just connect wirelessly, and that gives some beautiful pictures.
Yes.
And all I can say is that the future is bright, and we are looking forward to that.
Yes, very much so.
So, Adrian, there is a bit of ethical aspects as well that we need to touch base. What is your take on this ethical considerations in terms of use of ultrasound in advanced life support?
Yeah, I mean, I think at the moment, I would say that the evidence is uncertain. So I think that I think the statement by ILCOR, while I understand why they have said it, I'm a little disappointed in it. I would have thought that maybe they could have suggested that there might be more room for the use of ultrasound, because we just don't know. We have theoretical reasons why it might be very beneficial. We have theoretical reasons why it might actually be harmful. We really have no evidence. In that setting, I certainly don't think it's wrong to perform echo in life support. I wouldn't do it if that were the case, but I do it because I do think that if you do it correctly, it is probably going to be of benefit. And there is no evidence to say that that's not the case. I also think that it would be that we need a trial. I don't think there would be any ethical problems with conducting that trial, because we're in this point of just not knowing.
Excellent. Thank you for sharing that. You have already showed us some interesting cases, Adrian. Do you have any other interesting cases where you feel that the ultrasound has made some impact in the assessment and management of a patient of advanced life support?
Yes, yeah. So, I mean, this is my favorite case from performing echo. Hopefully that's coming up. And the image is frozen. There we go. Let's see if I can get it.
That's
So
beautiful.
this was an elderly gentleman who was actually up a ladder doing some painting of his house when apparently he felt a little funny
Mhm.
and climbed down and was sort of on the lower step. When he fell back, collapsed. As he was hypotensive when the ambulance picked him up. As he was brought into hospital, when he was just a few minutes out of hospital, they said they lost the pulse. So they commenced CPR. He was brought in to the department receiving CPR. And on the first pulse check, this is what we saw. Um, and again, this was the case, as everybody, hopefully that's coming through and everybody can see. There's a large pericardial effusion there. Sorry, my computer's going a little slow there. And so this was the case where I said to the team leader that CPR wasn't going to be effective. The heart was actually contracting, had minimal output with it because of this large pericardial effusion. So I'll show you, this is from the subcostal view.
Wow.
And the other thing we can see on that is that that looks like blood clot sitting in the pericardium. So we had no real idea what the cause of this was. Dissection is one of the first things that comes to mind. But we performed pericardiocentesis. We put a pigtail drain in, took off 200 mils, and this is towards the end of that drainage, and the blood pressure returned. He had a blood pressure of about 130 or 140 millimeters of mercury, systolic blood pressure. And so at that point, we took him straight through for a CT angiogram, thinking that this is likely going to be an aortic dissection. We called cardiothoracics at the same time. They came down, they met us in CT just as this was being done, and that showed no dissection. He was known to have a right atrial occlusion device, which had been inserted because he had atrial fibrillation, but he'd had a previous intracranial hemorrhage. So anticoagulation was contraindicated. So they put in left atrial occlusion device. Right. So he came out of CT back to resus. His effusion reaccumulated and we reaspirated it. His blood pressure dropped. Again, we reaspirated. His blood pressure came back up. The cardiothoracic surgeon was there. He'd had a look, talked to the radiologist. Nobody could see where this bleeding was coming from, but it was obviously reaccumulating very rapidly. So the cardiothoracic surgeon did a subxiphoid window in the department. And again, blood pressure came back up. And the plan was then to take him up to theatre. But the rate of bleeding was very brisk through this subxiphoid window. And so the cardiothoracic surgeon actually decided that he'd do a thoracotomy in the department. He said, it's bleeding too rapidly. They can't control it from the subxiphoid window. They could stop it retamponading. But they actually did a median sternotomy in the department, which is pretty unusual. They got the saw down from theatre. I think they brought it down with them. So they did a median sternotomy in the department, and he said, oh, there's a little hole in the pulmonary artery. Stitched it, stopped the bleeding, took him upstairs, washed it all out. And the patient recovered and left hospital a few days later, actually. So interestingly, the device hadn't eroded through the left atrial appendage, but they think that the pressure of it basically rubbing backwards and forward on the pulmonary artery had caused a little hole in the pulmonary artery.
Wow.
So he had a really good outcome. And I mean, to be fair, that is an unusual resuscitation case. both in terms of the cause and in terms of the outcome. But certainly, if we hadn't done that echo, there is no way anybody would have considered the cause as being tamponade. And I have no doubt that he would not have survived that episode.
This is such an interesting case, and it shows that the ultrasound can be useful in such a tremendous way in case of advanced life support. But again, we need evidence in terms of randomized control trial to prove that, which I'm pretty sure that will be done in the near future.
Yes.
But thanks for sharing this very interesting case. I really enjoyed this. This is one of those one in million case probably.
Yes.
That showed that how useful the ultrasound is. Thanks for sharing that excellent case, Adrian. So we have already talked about a few of these topics. There are a lot of myths about the use of ultrasound in advanced life support, but the reality is a little different. And these myths not only applies for advanced life support, but also in some of the general ultrasound. Let's focus on those one at a time, Adrian.
Yes.
So one of the myths that I hear from many of our colleagues, especially who are not using ultrasound that often for advanced life support, is that the ultrasound is only for the experts. What is your take on it?
Look, I think ultrasound, like many other things, the more you learn, the more useful it will be. But even if you don't know very much, there are some things that with ultrasound ultrasound is very good at answering some clinical questions that are otherwise really, really difficult to answer. But with ultrasound, it's quite easy. And the sorts of things that I use as examples of this are, is there an abdominal aortic aneurysm? That's really hard. I mean, you probably remember being taught as a medical student, you're supposed to bring your fingers in from the side. If the pulsation goes that way, it's a transmitted pulse. If it goes that way, it's an aneurysm.
Exactly.
Really? Whereas most of the time you can put a probe on and you go, there it is. It doesn't take much training to be able to see a big pulsating aorta and go, that's an aneurysm. The other thing is tamponade. I mean, to clinically diagnose tamponade with confidence is really, really difficult. Pulsus paradoxus, poor perfusion, muffled heart sounds. I mean, I'm kidding myself if I think I can do that accurately. But with echo, even just a single subcostal view, again, it's one of the simplest things that you can learn how to do with an echo probe. And yet it answers a question that is really, really difficult otherwise. So what I say to people is, look, when you're starting off, when you're trying to learn, pick these things that are technically easy to do with an ultrasound, but answer questions that are clinically really, really difficult. So the tamponade, the AAA, is the pregnancy intrauterine or not? When people talk about, you do a pelvic exam and you try and feel whether there's a pelvic mass to diagnose an ectopic. And I just think, hey, maybe if you're a senior gynecologist, you can do that. But for all the rest of us, no way. Give me an ultrasound probe instead. Not because I'm going to diagnose the ectopic, because that takes a bit more skill, but because if I put the probe on and I see a uterus, and inside that uterus I clearly see a gestational sac with an embryo, with a heartbeat, which makes it easier to see, then I can go, yeah, all right. If I did see that and no free fluid, I've pretty much diagnosed no ectopic, And yes, there's the really rare edge case, heterotopic pregnancies, all these things. But these are really simple things to use from an ultrasound perspective. You don't need to have 5 years of training as a sonographer to answer those questions. You learn those things pretty quick, and yet they answer the questions that we really struggle with otherwise.
Excellent. Thank you. So you don't need to be expert. It needs some training. It needs some supervision and lots of practice.
Yep.
And if we can practice in the stable patients, in case of cardiac arrest, that becomes super useful.
Yep. Yes, agreed completely.
The second myth that I hear from many of the colleagues is ultrasound is time consuming, and some of the colleagues actually say that you are wasting time, see some patients. What is your take about it?
Look, I think when you start, you're going to be slow. Ultrasound is going to be a bit time consuming when you start. But I think that you very rapidly, the learning curve is quite steep and you will get quicker very rapidly. And so, certainly for me, and I do a lot of ultrasound, I've been doing it a long while. It's quicker for me to do an ultrasound to answer the question than to try and do all the other things often. I can often do an ultrasound whilst I'm talking to the patient. And so that combined time of history and ultrasound is really not much more than just the history. And because I'm doing the ultrasound, I might be able to curtail some of that history and particularly the examination. And I think also from the department's point of view, it's often, and I hear this argument and I understand this argument, but I think it underplays how much the patient flow can be improved by doing ultrasound. Because, for example, if somebody says to me often, I've got a patient there, I think they might have a DVT. Now, yes, I can take a history, I can examine them, I can take a blood test, I can do their pretest probability, I can send off a D-dimer, I can get the result, and then I can decide whether or not they need further investigation. But to be honest, most of the time I'll look at them and I'll go, just jump up on the bed, I'm going to do a scan. And, so long as they haven't got huge, massive legs and they're technically very difficult, it might take me 10 minutes to do that. And at the end of the 10 minutes, I can say, you don't have a deep vein thrombosis in that leg, you can go home. Or I'll say, you do, and I'm going to do whatever I need to do with them. But if you want me to clear that cubicle quickly, I'm just going to go in and do the ultrasound, because not only is that quicker for me, it's much quicker for the whole department and for the hospital and for the patient as well. But yeah, that takes a little bit of time and practice. So as I said in the answer to the last question, I think you've got to be a bit selective when you start. Don't start with the thing that's going to take you an hour when the department's falling apart and horribly busy, and you're going to get an answer that you're not going to be confident of because it's a technically really difficult scan. Start with the thing that's going to be quick and easy, because the patient you don't have to send for an abdo-CT as query AAA, that's just saved a lot of time for everybody. Now, you might say, oh, well, if they're going for a CT abdomen anyway, well, that's a different matter. But, they come in and they go, oh, look, this patient, I think they've just sprained they've got a back sprain, or they've strained it because they hurt it while they were gardening. But I'm a bit worried about maybe it's a AAA because maybe there's a bit of a pulsation. Now, you either take a gamble and don't do any imaging, or if you don't do ultrasound, you've got to then try and persuade the radiologist to do a CT that they think it's probably going to be normal, and it probably will be. You've got this whole train of things that are going to happen that's going to block up your whole department. Or you can push the ultrasound in, and if they're a thin elderly person, and then you say, yep, that's it, that's sorted. I don't have to do all those other things. So you've got to pick your patient, you've got to pick your scan, but if you do it right, ultrasound saves time overall. And as you get a bit more experience, the range of things that happens for gets ever increasing.
Excellent. Thanks for clarifying that myth. And another myth that I can hear, or that is the perception of some of the clinicians, is that ultrasound can replace the physical examination. What is your take, Adrian?
Look, I think ultrasound doesn't replace physical examination. I often combine ultrasound with physical examination because I know where it's going to be sore, but instead of pressing with my hand, I press with the ultrasound probe. I think in some ways, I think of physical exam, I try and approach it the same way as I do ultrasound or any other investigation. I need it to answer a question for me. Does this patient have whatever? Do they have an abdominal aneurysm? Have they, ruptured their papillary muscle and now they've gone into crashing pulmonary edema? Now, there are some things that physical exam is really good for. If you look at, say, the HINTS test, if done properly and you're experienced, then that's better than an MRI.
Exactly.
For diagnosing strokes.
Mm-hmm.
But there are some things physical exam is hopeless for, such as, does this patient have a lot of free fluid in the abdomen? Now, okay, if they've got massive ascites, it's easy. But, the trauma patient, do they have free fluid? The query ruptured ectopic, physical exam for that is terrible. So I would say, as a complete statement, that is wrong. Ultrasound cannot replace physical exam. But what I would say is ultrasound can answer some questions that physical exam cannot. But yes, you don't replace physical exam. And physical exam, in general, it's rapid and it's cheap and it has minimal side effects. So it should still be, after the history, our starting point to then create all our pre-test probability that we then go the next step for whatever investigations.
Thank you. So ultrasound can actually be an adjunct to the physical examination.
Absolutely, yes.
Thank you. There is a myth that ultrasound is invasive. What is your take on it, Adrian?
As a general statement, no. There are some forms of ultrasound that are invasive to different extents, like transesophageal, transvaginal, and you can actually also do intravascular ultrasound. We don't do it, but some of the vascular surgeons and some of the cardiologists do. Mm-hmm. But, when we routinely talk about ultrasound, no, it's not invasive. Now, it has a very, very good safety profile. We do have to bear in mind that there are bioeffects from ultrasound, so there are certain things we need to be a bit cautious about. We need to be cautious when we're doing ocular ultrasound that we use low energy, because we don't want to heat the eye. We need to be careful when we're inseminating early pregnancy, particularly in that very small embryo phase, because we don't want to cause any heating of the embryo. We also don't want to excessively insunate the lung and put high power through the lung, because we know we can actually cause pulmonary hemorrhage if we use high ultrasound power. So, everything has pluses and minuses, risks and benefits. We need to know them. We need to minimize the harms that we cause. But overall, I'd say no, ultrasound is not invasive, and more importantly, it's a very safe modality.
Excellent, thank you. There is another misunderstanding or misconception, or myth rather, that ultrasound is only for cardiac arrest. How do you feel about that? What is your take, Adrian?
Most of the ultrasound I do is not for cardiac arrest. That's a very small part of what I use ultrasound for. Even if we're talking about the basic echo, I would still say most of the time you're not going to be using it for cardiac arrest. And if at all possible, try and use it before they get to cardiac arrest. Now, sometimes we don't have that option, but I'd very strongly recommend, like everything we do, don't wait for the patient to arrest. Try and get in there before and prevent the cardiac arrest.
Ultrasound image quality, that's a big topic, especially in case of the young trainees. They feel with lack of confidence that they are not getting the best picture, especially in case of the cardiac arrest scenarios. What is your take on this myth, Adrian?
Yeah, I mean, the ultrasound image quality needs to be good enough for you to confidently answer the question that you're asking. And depending on what that question is, it's going to depend on what level of quality you need, which is why, for example, if people say to me, should I be trying to measure the aortic valve gradients? I'd go, no, not until you have a lot of experience, not until you can get images of very high quality. Because if you want to answer that question accurately, you need to be able to have very high quality images. On the other hand, what level of quality do you need to get to answer the question, is there a big pericardial effusion? Well, fortunately, you don't need very high quality at all to answer that question.
Mm-hmm.
So, as I said, perfect, we work in emergency. We might aim for perfect, but we very, very rarely get there. It's got to be good enough to answer the question, and you need to know how good it has to be for your question. And don't try and use it for things where you need much higher quality to answer those questions.
Excellent. Thank you for sharing that. One of the myths is that ultrasound in advanced life support is not evidence-based, and we have talked about it. Please tell us a little bit more about this myth.
Well, I mean, I would say the evidence is weak. And so in that sense, you might say, well, it isn't evidence-based. But I would also say, well, most of what we do in ALS is not evidence-based. We'd like it to be, and slowly the evidence base is improving. But a lot of what we do is not evidence-based. We've got to make the best of what evidence we have. There is some evidence for ultrasound in ALS. It's not great quality. I certainly advocate for let's get some better quality to improve the evidence base. But I think it's a little harsh saying that there's no evidence base. And I'd also point out that there's an awful lot of other stuff in ALS that is at that same category as well.
Excellent. Thank you for that. What is the implication of this ultrasound use in ALS for the emergency department, Adrian?
Well, I think that the main implication is for training. As I mentioned, I think most places now have the equipment. What we need is the training for everybody to be well practiced in this, to be able to do it without causing breaks in CPR, and for the whole team to understand how this is performed and how it works and how to do it without causing any adverse effects.
Excellent. Thank you very much. So we are nearly at the end of this talk, Adrian. What will be your main tips and tricks or advice to the clinicians who are using the ultrasound in advanced life support or are training or getting involved in this process of learning this?
I mean, I think as I've said, and I'm probably starting to sound a bit like a broken record here, my main advice for people is just practice. Even if I know it's hard to start with, and I know you're really busy, but it will pay off, I promise. So get some practice, just keep trying to do it, little bit, and then you'll find suddenly you're going to be getting better images much faster, and you're going to start getting really useful information. And then you're going to have a case and you think, wow, if I hadn't used ultrasound, I would have been totally sunk. there. So that's my main advice. In terms of specific tips and tricks, I mean, those are the things that I've mentioned before. Don't just use the subcostal window. Don't just look during the pulse check. And make sure your team is all practiced and you know how to do this without interrupting the overall flow of the advanced life support algorithm. And don't extend the breaks in CPR.
Excellent. Thank you for those gold nuggets for sharing with us. There are quite a few articles on this topic, and the main topic that we focused on is the recent paper that was published in Diagnostics. And also there are quite a few papers which talk about this use of ultrasound, the debates, the usefulness, or they are controversial. Once again, Adrian, it was a great privilege having you here, and thanks for sharing with us all your thoughts, all your expertise, and those beautiful clips from your collection. I'm really fascinated by seeing the use of ultrasound in advanced life support.
All right. Well, thank you very much. I mean, it's been a real pleasure to talk to you and for you to listen to me talk and talk and talk. Thank you very much, and I hope people have gained something from it. And yeah, very happy to answer any questions that people have if they want to drop me a line. Otherwise, we'll probably see you around somewhere in one of the conferences somewhere.
Thank you very much, and I hope that we'll see you again. Thank you, Adrian. Okay.
Bye then.
Now.
Thank you.